It's funny when you think about it, medications are just, they're everywhere, aren't they? I mean, from life-saving emergency drugs to, the daily pills people take for chronic conditions. But do you ever stop and wonder how they actually work? Like, really work beyond just swallowing it. Today, we're doing a deep dive into some of the most common, most critical drug classes out there. We want to sort of pull back the curtain, cut through the medical jargon, and really get to the core of what these drugs do inside the body. Our mission, really, is to give you those aha moments about how these essential meds work and the things you absolutely need to know. We've got some great sources, clinical examples, key rationales. Should be good.
That's exactly right. We'll be looking at a whole range, emergency stuff, long-term management drugs, focusing on how they work, sure, but also the really crucial patient implications. That's what turns info into real understanding, I think.
Okay, let's dive in. Starting with the body's own messaging system, the nervous system. Let's unpack the fight or flight drugs first.
Right, fight or flight. And the big one there is epinephrine. Think of it as the body's master key in an emergency. It hits multiple receptors, multiple locks, if you will. Alpha-1 tightens blood vessels, raises blood pressure. Beta-1 speeds up the heart. And crucially, beta-2 opens up the airways in the lungs.
Interesting. I think most people associate epi with blood pressure, especially in anaphylaxis, right? Severe allergic reaction. But you mentioned something surprising, that a key sign it's working isn't just BP, it's improved wheezing. Why is that the most critical thing to look for?
Yeah, that's a fantastic point. Because in anaphylaxis, often the immediate life threat is that airway closing up. You can't breathe. So while, yes, epi raises blood pressure, which is important, the bronchodilation, that opening of the airways from hitting beta-2 receptors, that's the immediate lifesaver. Seeing the wheezing improve means they can actually get air in.
Wow. Okay, so for anyone listening who might carry an EpiPen or similar device, what's like the one practical thing that they have to remember?
Oh, definitely. Inject it firmly into the outer thigh. And yes, right through clothes is fine in an emergency. Hold it there for a few seconds, but don't, rub the area vigorously afterwards. Just let it absorb. And keep it at room temp, no extreme heat or cold. You might feel your heart race get shaky, higher BP.
Huh.
But that's expected. It's doing its job.
Okay, so if epinephrine is the gas pedal, then beta blockers like Atenolol, they're kind of like the brakes for the heart. What's the main idea there?
Exactly. Good analogy. Beta blockers block those beta-1 receptors, mostly on the heart. So they slow the heart rate down, lower blood pressure. The absolute #1 thing to teach patients. You never just stop taking them suddenly. Never.
Why not? What happens?
You can get this dangerous rebound effect.
Yeah.
Your blood pressure could shoot up. You could get severe chest pain, angina, even a heart attack. It's serious. And always check your heart rate before taking a dose. If it's below 60 beats per minute, you typically hold off and check with your doctor.
Below 60. Got it. That makes total sense. Don't want to slow it down too much. And I heard there's something tricky for people with diabetes, a hidden side effect.
Yes, this is a really important one. Beta blockers can actually mask the usual warning signs of hypoglycemia, low blood sugar. Things like a racing heart or feeling shaky might not happen. So if you're diabetic on a beta blocker, you have to be extra careful monitoring your blood sugar levels. Oh, and fatigue, dizziness, those are common too. So telling people to get up slowly helps prevent falls.
Okay, shifting gears now. Let's move away from fight or flight and talk about the rest and digest system. There's a drug called Bethanechol chloride. What's its job?
Right, Bethanechol. It's a cholinergic agonist. Basically, it mimics the body's rest and digest signals. It stimulates receptors to increase urination and get the bowels moving, peristalsis. So it's often used for urinary retention, maybe after surgery, or to help stimulate bowel function.
So pretty straightforward to see if it's working then. You'd expect, well, more bowel sounds and urination.
Exactly. It's quite direct.
Yeah.
And a key point for taking it, usually on an empty stomach, helps minimize nausea or vomiting.
Okay. And any reason someone shouldn't take it?
Oh, absolutely.
Yeah.
It's contraindicated if there's a physical blockage, like if someone has an enlarged prostate, BPH, making it hard to urinate. This drug would just increase pressure without fixing the blockage. Same idea for a bowel obstruction.
Makes sense. So if Bethanechol gets things moving, then Atropine sounds like it does the opposite. What's its main priority use?
You got it. Atropine is an anticholinergic. It blocks acetylcholine, that rest and digest messenger. So it does the opposite. Increases heart rate, decreases secretions, dries things up. Its most critical use. Treating symptomatic bradycardia, a dangerously slow heart rate. We also use it sometimes before surgery to reduce saliva and other secretions.
Okay, so because it speeds up the heart, the first thing you check before giving it is?
Heart rate, absolutely. If the patient already has tachycardia, a fast heart rate,
Mhm.
you wouldn't give atropine. It would just make it worse.
Right, don't want to pour fuel on that fire. And you mentioned it dries things up. Are there common side effects people should expect with these anticholinergic drugs? Like not just atropine, but maybe others like Benztropine for Parkinson's or Tolterodine for overactive bladder.
Yes, that's a great connection. They often share those classic anticholinergic side effects because they work similarly. Think dry mouth, constipation, blurred vision, and trouble urinating or urinary retention.
Practical tip for the dry mouth.
Sucking on sugar-free hard candy or sipping water often helps. And yeah, with Tolterodine, you monitor for urinary retention. With Benztropine, you have to be cautious if someone has narrow-angle glaucoma. It can be risky.
Okay, let's transition now to drugs that work more directly on the brain and muscles, especially for neurological conditions.
Carbidopa-Levodopa. This is really the cornerstone for Parkinson's disease. Levodopa is the part that actually gets converted to dopamine in the brain, which is what's deficient in Parkinson's. Carbidopa is like its bodyguard. It stops the levodopa from breaking down in the rest of the body, so more gets to the brain. The result, better mobility, less tremor, less rigidity. It can be life-changing.
And there's that really interesting kind of counterintuitive teaching point about diet, right? Something about protein.
Yes. High-protein meals can actually interfere with levodopa absorption, reducing its effectiveness.
So you need to avoid protein.
Not avoid it entirely, no, but it's about consistency. Keeping protein intake roughly the same day to day, and sometimes doctors advise timing doses away from high-protein meals. It's something to discuss with your provider.
Good to know. What about common side effects people should be aware of?
Dyskinesias are pretty common, those involuntary kind of jerky movements, and orthostatic hypotension, that dizziness when you stand up quickly, which means a fall risk. Oh, and tell patients not to worry if their urine turns dark, like cola-colored. That's a harmless side effect.
Okay. Moving on to Alzheimer's, there's Donepezil. How does that one work?
Donepezil is a cholinesterase inhibitor. It basically boosts levels of acetylcholine, another key brain messenger involved in memory and thinking, by stopping the enzyme that breaks it down.
And the crucial thing for families to understand here is
That it helps manage the symptoms, it can improve memory, help with a daily functioning for a time, but it's absolutely not a cure. It doesn't stop the underlying disease progression.
right, managing expectations is key. Is there a particularly serious side effect to watch for?
Yes, the priority one is bradycardia, slow heart rate that leads to syncope or fainting. If that happens, it needs urgent medical evaluation, definitely.
Okay, let's switch focus again, this time to the heart itself. Cardiac medications. These are vital for keeping the heart beating correctly.
Let's start with Digoxin. It's an older drug, but still used. It has this really interesting dual effect. It's a positive inotrope, meaning it makes the heart muscle contract more forcefully, squeezes harder. And it's also a negative chronotrope, meaning it slows the heart rate down. So stronger beats, but fewer of them per minute.
Stronger but slower.
Okay.
And because it slows the heart rate, that vital check before giving it is...
Taking the apical pulse, listening right over the heart for a full minute.
Yeah.
And you hold the dose if the heart rate is less than 60 beats per minute. Very important check.
And toxicity is a concern with digoxin. What's a major risk factor, and what's that really classic, almost bizarre visual side effect people might experience?
Big risk factor.
Yeah.
Hypokalemia, low potassium levels. Low potassium makes the heart much more sensitive to digoxin, increasing toxicity risk, and the classic visual symptom. Besides nausea, patients might report seeing greenish-yellow halos around lights. It's very specific.
Wow, green-yellow halos. Definitely memorable. Okay, how about nitroglycerin? Famous for chest pain. But you mentioned a side effect earlier that actually tells you it's working.
Yeah, the headache. Nitroglycerin is a potent vasodilator. It opens up blood vessels. This reduces the heart's workload and improves blood flow to the heart muscle itself. That vasodilation also happens in the head, causing that common headache. So, while uncomfortable, it often means the drug is active.
A headache means it's working. Interesting spin. And for the sublingual tablets under the tongue, what are the absolute must-know instructions?
Okay, critical points. First, sit down before taking it. It can drop your blood pressure quickly and make you dizzy. You can take up to 3 tablets, 5 minutes apart. Keep them in their original dark glass bottle light and moisture ruin them. And this is huge EE. If the chest pain isn't relieved after the first dose, call 911 immediately. Don't wait to take the second or third. Call 911. Also, extremely important, never ever take nitroglycerin if you've recently taken erectile dysfunction drugs like sildenafil, Viagra. The combination can cause a catastrophic drop in blood pressure.
That's a life-saving warning.
Absolutely. And one more thing for nitro patches. People usually take them off at night for a nitrate-free period. This helps prevent the body from getting used to it or developing tolerance.
Gotcha. All right, let's talk about amiodarone. Sounds like a heavy hitter for serious arrhythmias, but comes with a lot of baggage.
That's a fair way to put it. Amiodarone is very effective for tough heart rhythm problems, but it has a significant side effect profile. The absolute most critical one to watch for is pulmonary toxicity. If someone develops a persistent dry cough, shortness of breath that needs an immediate ER visit, it can damage lungs. It can also mess with your thyroid, causing either hypo or hyperthyroidism. Liver toxicity is another risk. And then there's the really unique one, photosensitivity, which over time can actually cause the skin to turn a bluish-gray color, especially in sun-exposed areas.
Bluish skin. Wow.
Well,
So lots of monitoring needed then. Regular thyroid tests, liver tests, eye exams, and strict sun avoidance.
exactly. It requires very close follow-up and patient awareness.
Okay, final section. Let's dive into blood thinners and cholesterol meds, often long-term, requiring careful attention.
Let's start with warfarin, maybe the most well-known oral anticoagulant, or blood thinner. It works by interfering with vitamin K-dependent clotting factors.
Right, the vitamin K connection.
Yeah.
And this leads to probably the biggest point of confusion and the most crucial teaching point, doesn't it? It's not about avoiding vitamin K.
Exactly. This is so important. You don't avoid vitamin K, which is in healthy foods like leafy greens. The key is consistency. Keep your intake of vitamin K consistent from day to day. Big swings in intake will make your INR, the test measuring clotting time, go haywire. The goal is usually an INR between 2.0 and 3.0 for conditions like AFib, and consistency helps keep you there.
So consistency is king. What else for warfarin users?
Expect frequent INR blood tests, especially initially. Be super careful about starting any new medications or herbal supplements. Tons of interactions. Wear a medical bracelet or carry a card. Know that the antidote is vitamin K. And remember, warfarin prevents new clots from forming or existing ones from getting bigger. It doesn't dissolve clots that are already there. Oh, and often, when starting warfarin, you'll also be on heparin or enoxaparin for a few days, because warfarin takes time to reach its full effect. That overlap is necessary.
Speaking of enoxaparin, or Lovenox, that's a low molecular weight heparin. Any key differences from regular heparin or warfarin?
Big difference. With enoxaparin injections, routine blood monitoring like APTT or INR usually isn't required, which is convenient. And a practical tip, don't rub the injection site afterwards. It can increase bruising. Heparin the fourth, on the other hand, does need close monitoring with APTT, and its antidote is protamine sulfate.
Okay, and then there are newer ones like Apixaban, Eliquis. What's the main message there?
For Apixaban and similar drugs, the key message is bleeding risk awareness. Report any unusual or excessive bruising or bleeding. Immediately nosebleeds, blood in urine, black tarry stools. Big advantages are no routine INR monitoring and often fewer interactions. But crucially, never just stop taking it without talking to your doctor. Abruptly stopping can increase clot risk.
Right. Now, antiplatelets, aspirin and clopidogrel, Plavix, they stop platelets from sticking together. Anything specific to highlight?
For aspirin, besides its antiplatelet effect, watch for tinnitus ringing in the ears, which can be a sign of toxicity, and be cautious with GI bleed history. For clopidogrel, similar bleeding precautions, it also irreversibly affects platelets. And here's a surprising interaction. Omeprazole, that common heartburn medicine, can actually reduce clopidogrel's effectiveness.
Omeprazole. Wow, millions take that.
Yeah, it's an important one to be aware of. Also, clopidogrel usually needs to be stopped about 5 to 7 days before planned surgery because of the bleeding risk.
Okay, almost there. Statins. Atorvastatin, rosuvastatin for high cholesterol. What's the big misunderstanding you mentioned?
The biggest one is people thinking they can stop taking their statin once their cholesterol numbers look good. No, these are generally meant to be lifelong medications. They work to keep your cholesterol low and reduce your long-term risk of heart attack and stroke. Stopping them means your cholesterol will likely go right back up.
Lifelong commitment, okay. And the most important side effect to report immediately.
Unexplained muscle pain, tenderness, or weakness.
The what?
This could be myopathy and in rare cases lead to rhabdomyolysis, a serious breakdown of muscle tissue that can damage the kidneys. Don't ignore significant muscle aches. Also need regular liver function tests, avoid excessive alcohol, and usually grapefruit juice. And an interesting detail, people of East Asian ancestry might need lower doses of rosuvastatin, and poor kidney function increases the myopathy risk with statins in general.
Wow, okay. We've covered a ton of ground. That was a fantastic deep dive into some really common and critical drugs, from EpiPens to statins, really understanding the how and the why.
Exactly. And hopefully, Understanding the mechanisms, the key monitoring points, the potential side effects, it empowers everyone listening. Whether you're taking these meds, caring for someone who is, or just want to be more informed about health, it connects the dots.
Absolutely. That's what we aim for. So, thinking back on everything we discussed, what's maybe one thing that really stood out to you today, or something that might make listeners rethink a common medication?
Maybe just how much seemingly small things matter, like the consistency of vitamin K with warfarin, or avoiding grapefruit with certain drugs, or timing Parkinson's meds around protein. These aren't minor details. They can significantly impact how well a drug works and how safe it is. It really makes you think, doesn't it?
That
How can this deeper understanding change how you approach conversations about your own health or the health of people you care about? How can it empower you to ask better questions?
Definitely food for thought. Something to mull over until our next deep dive. We really hope you feel more informed and maybe even a little more curious about the medicines in your world.